Hello everyone. Today we'll be discussing about a very interesting neuroradiology case in which multiple MRIs and CT scans were done for the problem of the patient, but a final diagnosis could not be reached. So the patient was referred to me with all these MRIs and the clinical findings which I examined, and then we came to a conclusion. This 43-year-old female came to me with the complaints of left eye ptosis for 1 month now. She had a whole history of trauma about 4 to 5 months back, but that was conservatively managed. So when examination was done, we could see that there was left eye or bital complaints. The eye was laterally deviated with restricted motion medially, and pupil was dilated and fixed. It was not reactive to light. Consensual reflex on the other side, that is right eye, was present, and the right eye other reflexes were also okay. Now, considering this as a third nerve palsy, I also wanted to examine other nerves which are associated generally with third nerve palsy. So fourth nerve and sixth nerve were examined and looked fairly fine. Fifth nerve examination was also normal. Corneal reflex was okay. So considering this case as a third nerve palsy, I saw the MRI. The outside MRIs and the films which I had showed the third nerve on the left side fairly fine, and there was no abnormality in the parenchyma as well. So I thought I'll do one more MRI here and look for third nerve involvement. When MRI was done, from the brainstem to the orbit, third nerve was fairly well visualized with no abnormality. However, on T2 space sequence, there were hypointense signal in the left cavernous sinus, preferentially in the posterior part of the left cavernous sinus. I did the TOF MRA sequence because there was involvement of the third nerve without pupillary sparing. So there can be external compression due to ACOM aneurysm or TOF angiogram. I was able to see some flow related enhancement in the left cavernous sinus posterior region, and that flow related signal was seen extending into the left and the right IPS as well. ASL brain perfusion also showed artifactually increased perfusion in the left cavernous sinus region. Now all these findings of T2 hypointense flow voids in the left cavernous sinus associated with increased flow related signal on TOF images and ASL, finding of fistula was considered. After this, we took the patient for DSA, and DSA of bilateral ICA and ECAs showed left cavernous sinus indirect CCF with supply from both the ICAs and the ECAs. Here the interesting thing is, the flow was preferentially going posteriorly into the IPS. No flow was seen going into the SOV. That was very well visualized on MRI, and MRI did not show any abnormality of superior ophthalmic vein bilaterally. This is the reason why there was so much delay in the diagnosis of the left indirect CCF. Indirect CCF cases have flow in the SOV, and the patient presents with proptosis, exophthalmos, sometimes chemosis, but here, as the flow was posteriorly deviated, there was no eye complaint other than third nerve involvement. So this case highlights the importance of the clinical examination and the sequences of MRI which should be selected by the neuroradiologist while the MRI is being done, so that specific MRI sequences can be analyzed and added as and when required. So always evaluate your patient clinically, decide the sequences beforehand, and add any sequence on table if the patient requires. For any queries related to neuroradiology, put it in the comment section below and let me know. Thank you.